Shall we start now? Is it 9? So, shall I start? Okay, so let us start now. I think it's time. So let us start the session. Good evening. Uh, Here are we again with the previous year questions of INI exams. Since you know that previous year questions, they are of essence while we are being, preparing for the INI exams, because many times repeat questions are asked exact same to same or with some changes. So both for NEET-PG, but most of the time, as well as INI is concerned, previous year questions are asked very often. So let us start with the session of a quick revision of the previous year questions. The first is an image-based question in which identification of the condition was asked. Now, see, if you are given in the question such images where there are a mixture of many images are seen, the first thing is to always look at the central image. And if we look at the central image only, we appear at the diagnosis, because in the central image we are being shown ptosis. We are being shown ptosis, and we know ptosis, that is LPS muscle is gone, and we know straight away that it is the palsy. But still, if we want to look at the other options, let us try. So the first, the patient in the normal gaze, patient has ptosis. Now, if we look at the other diagrams, see, we know that in patient in his left eye there is loss of adduction. This eye is abducting normally. Right eye is abducting normally, while the left eye it is not able to adduct. That is medial rectus. There is problem in medial rectus because this eye is abducting normally, while it is adducting, there is problem in adduction of this eye. It means medial rectus is gone. So we have two muscles which are not working properly, LPS and medial rectus. If we look at the other images, here we can see there is some problem in the upward movement also. That is, it means either the superior rectus, okay, or the inferior oblique, because these are the two muscles responsible for the elevation. So if we combine all of these muscles, we know that by the formula LR6SO4 rest free, the diagnosis is the third nerve palsy. The diagnosis comes out to be the oculomotor nerve palsy, because all of these muscles which we discussed are, their function is deficient. So this is a very straightaway question. Even for this question, you need not to look at the other images, but if you want to be sure, you can look at the other images also, and the answer comes out to be the third nerve palsy. Other options, if the medial rectus was bone only, the LPS muscle should have been normal. In trochlear nerve palsy, okay, in the trochlear nerve palsy, the patient would have been problem in depression and intorsion, because superior oblique is responsible for depressing the eye, and trochlear nerve supplies the superior oblique muscles. Similarly, in abducent nerve palsy, there could have been a problem in the abduction. Okay, so the answer comes out to the third nerve palsy. Next question is, oculocephalic reflex assesses which of the following nerves? Okay, so it is a multiple answer question, because we are given some of the options and we have to look at the options which are a combination of the given options. So firstly, look at what is oculocephalic reflex. Oculocephalic reflex, or also known as vestibular ocular reflex or doll's eye reflex. Vestibulo-ocular reflex, doll's eye reflex. Now, what does reflex is? This reflex, basically, it depends on whenever we turn our head. Okay, so let us look at this image. When a person turns his or her towards one side, for example, he turns his or her head towards the right side. If we turn our head towards the right side, it excites or it gives positive signals to the eighth nerve. Eighth nerve of the similar side gets excited or gets the positive stimulation. This again in further excites the sixth nerve of the opposite side. And we know that MLF, medial, okay, we know that in MLF connects sixth nerve, MLF connects the sixth nerve and the third nerve for the conjugate movement. MLF connects the third and the sixth nerve nucleus for the conjugate, or the what we call as the, because they both are the yoke muscles, they help in the conjugate movement of the eye. So they both are connected with the help of medial longitudinal fasciculus, that is MLF. So contralateral sixth nerve will excite the contralateral third nerve. Means the ipsilateral eighth nerve is exciting, giving positive stimulus to contralateral sixth nerve, which will further excite the contralateral third nerve for the conjugate movement. It means third nerve, sixth nerve, and eighth nerve, three of these nerves, they are involved in the oculocephalic reflex. Why this reflex is happening? Because when I turn my head towards right side, sixth nerve of my left eye is getting excited. It means it is abducting. So my left eye is going into abduction and my right eye, medial rectus, is getting stimulated. So my right eye is going into abduction. My right eye is going into adduction and my left eye is going into abduction. So that whenever I turn my head towards one side, my gaze is moving towards the opposite side. For not why? Because if my vision does not, or my ocular movements do not go to the opposite side, the I will have, or the patient will suffer from diplopia. So to minimize or to negate the diplopia, whenever we turn our head to one side, the eyes moves to opposite side. So for the movement of eyes to opposite side, my contralateral sixth nerve, that is my lateral rectus, and ipsilateral third nerve, that is the medial rectus, should get excited. So here the question was not asked about the direction or anything. It was just asked that oculocephalic reflex assesses which of the following nerves. That is a very simple we discussed. That is the third nerve, third nerve, sixth nerve, and eighth nerve. They are being tested in the oculocephalic reflex. And these options 1, 3, and 4, they are given in option number C. So third, sixth, and eighth nerve are tested in our oculocephalic reflex, and this is also the basis for the internal nuclear ophthalmoplegia. This is the basis of our PARC 3 step test, the third step of PARC test. So, what is happening in INO? Internal nuclear ophthalmoplegia, MLF, there is some problem in MLF. So, the third nerve and sixth nerve, they are not going to have a conjugate eye movement. So in baseline, the eyes are normal. When we move to one side, the both eyes, they are abducting and adducting normally. But when moved to the opposite side, one eye is not able to adduct. Medial rectus is not acting. And we know that one rule, whenever there is a problem in one muscle, its yoke muscle or its contralateral synergist muscle gets the extra supply. And because of this, the other eye suffers from nystagmus. Because of the excessive, supply to that muscle, it suffers from nystagmus. Now, if we talk about if this is the right eye and this is the left eye, which side of the MLF is gone? Which side of the MLF is gone? It is gone from the eye which is not able to adduct. That is, right side of MLF is gone. Whenever there is internal nuclear ophthalmoplegia, adduction of the paratic or the adduction of the abnormal eye is gone. Okay, adduction of the abnormal eye is gone. And why it is being hampered is because of the oculocephalic reflex. Whenever we turn our head to one side, the eyes have to move the opposite side. So the contralateral sixth nerve and ipsilateral third nerve have to act. Okay, so this is the oculocephalic or the vestibulo-ocular reflex. The next question is photoreceptors act by. Okay, now let us talk about physiology of the vision. We know that mechanism of vision, there are 3 steps in the mechanism of vision. First is the initiation of vision, that is the transduction. Next is the processing and transmission of the visual sensations. And third is the visual perception by the visual cortex. Here we are being asked about the photoreceptors. Now we know that initiation of vision is done at the photoreceptor level. So the question asked about it is about the first step, that is the transduction. Now let us look quickly what is transduction is. Okay, whenever we are in the dark, the rod cells, what is happening in the rod cell is the sodium ions are going inside. In the dark, the sodium ions are going inside the rod cell with the help of CGMP. And this is known as by the name of depolarization. That means in the dark, the cell is in depolarized state because the sodium ions are going inside. And since the sodium ions are going inside, they initiate or they help in the release of a neurotransmitter known by the name of glutamate. This is happening in dark. Now, whenever we know that the rod cells, the outer segment of the rod cells, they have rhodopsin. They have rhodopsin, which is made up of opsin and retinal. Whenever light strikes on rhodopsin, there is activation of a protein known as transducin. There is activation of protein in the rhodopsin, that is transducin. What this transducin does is it activates phosphodiesterase. Transducin further activates phosphodiesterase. And what this phosphodiesterase is doing, it is changing CGMP into 5-GMP. It is changing CGMP into 5-GMP. And this 5-GMP or increase of 5-GMP, or in the other words, decrease of CGMP, is closing sodium channels, because we know that CGMP allows sodium to go inside. Now, when CGMP is being decreased, the sodium ions are not able to go inside. That means the cell is going into hyperpolarized state. The cell is going into hyperpolarization. Okay. And when these sodium ions are not able to go inside the cells, the levels of the glutamate decrease. This is known by the name of hyperpolarization, which is happening when the light is striking on the photoreceptors. It means in the dark, the sodium channels are open and the cells are in a depolarized state. When the light enters the cell or the cells absorb the light, rhodopsin activates transducin, it activates phosphodiesterase, which decreases the level of CGMP, which closes sodium ions, and the cells goes in the hyperpolarized state. It means our photoreceptors act via hyperpolarization. This is just the written explanation of this diagram. Activated rhodopsin, which we call by the name of meta-rhodopsin, its activation is occurring in light, when light is being absorbed by the photoreceptors. Activated rhodopsin causes activation of transduction or the transducin protein via GTP-GTP exchange, which in turn causes activation of phosphodiesterase, which converts CGMP into 5-GMP. Decrease of CGMP closes sodium channels, leading to hyperpolarizing potential. It means our photoreceptors act by hyperpolarization. They act by hyperpolarization. And now we know that sodium ions, they were increasing the levels of glutamate. When there is hyperpolarization, means sodium ions are not going inside, the levels of glutamate decreases. So our photoreceptors act via hyperpolarization with decrease in neurotransmitter. Hyperpolarization with decrease in neurotransmitter. So again, if we discuss, in dark, the cell is in depolarized state. What will be the membrane potential? Depolarization means sodium ions are going inside. Plus sign is going inside. So there will be less negative. Okay, there will be less negative. So it is minus 40. While in light, hyperpolarization is occurring. Sodium plus sign is not going inside. So it will be more negative, 65. CGMP, they are high in dark state and low in light state. So the photoreceptors act via hyperpolarization and low neurotransmitter. Okay. So the next question is, which of the following has familial inheritance? Okay. Now we know that retinoblastoma, we study it as a high yield topic. Retinoblastoma is being discussed always very much in detail. And the start of retinoblastoma is always done with the topic that it has a familial inheritance. We always discuss retinoblastoma. It is both hereditary as well as non-hereditary. Although we know that non-hereditary causes are more, 60%, hereditary are 40% only, but there is familial inheritance seen in retinoblastoma, very easy. Retinitis pigmentosa, we always know it has autosomal dominant, autosomal recessive, X-linked recessive, all types of inheritance are seen. Autosomal dominant will cause familial inheritance. Okay, we know that retinitis pigmentosa. Myopia basically it is a multifactorial disease. It is a multifactorial disease. Environmental factors come into play. Even it has been seen that whenever there is a patient, especially of pathological myopia, that is more than 6 diopters. Whenever there is a patient of pathological myopia, it has seen that there are increased chances in the familial tree, there are increased chances of myopia are seen in the family tree. So myopia being a multifactorial disease, familial inheritance is seen especially in pathological myopia. Primary open angle glaucoma, familial inheritance is seen. As we discussed just few days ago in our previous 9 p.m. session, primary open angle glaucoma, we have discussed there is increase in chances, up to 10% increase in chances in family whenever a patient of primary open angle glaucoma is there. And we know that you have to remember, even if you don't know, you can remember now, there are the genes which are associated with primary open angle glaucoma. There are some of the genes, optineurin genes. These are some of the genes which are associated with the inheritance of the primary open angle glaucoma. So it is a very straightforward question. All of these diseases, they are known to show familial inheritance. So the answer becomes all of this, that is 1, 2, 3 and fine. Okay. The next question is, a 45-year-old man presents with lag of thalamus, skeletal muscle, orbicularis oculi palsy, similarly lag of thalamus, orbicularis oculi muscle, 7th nerve, and loss of corneal sensation, 5th nerve. Which of the following organisms is responsible for his condition? It is, this question is also very straightforward question. The answer is in the just first option only. Even if you do not read the other options, the answer is clear. Both the skeletal muscles and the corneal sensation are gone. 2 nerves are gone, peripheral nerves, 7th nerve, 5th nerve are gone, which is, we know that Mycobacterium leprae or leprosy, it is responsible. It is a disease of the peripheral nerves. So it affects both the 7th nerve, 5th nerve. So the patient will have skeletal muscle disease also, and there will be problem in the afferent supply also, because of which the corneal sensations are gone. Even if we do not know the option, we can have a look at the other options. Acanthamoeba. Acanthamoeba, we know that it causes radial perineuritis. We know that it causes radial perineuritis. It does not affect the skeletal muscles of the eye. It does not cause lag of thalamus or the orbicularis oculi palsy. Onchocerciasis or the river blindness, not seen in India, but river blindness or onchocerciasis, it causes vision loss by causing keratitis. It can cause vision loss due to optic neuropathy, chorioretinitis. It can affect the posterior segment of the eye as well as anterior segment of the eye, but it does not affect the eyelids. It does not affect the eyelids. It affects both the anterior and posterior segment and cause vision loss, but does not affect the eyelids. Chlamydia trachomatis, we know that chlamydia trachomatis, it is a cause of keratitis. We always discuss chlamydia as a high topic in detail as a part of conjunctivitis. Chlamydia is a part of conjunctivitis. Chlamydia is a part of keratitis. It does not affect the eyelids. So straight away our answer comes to Mycobacterium leprae. That is the leprosy which affects the peripheral nerve. It affects the 7th nerve. It affects the 5th nerve, which is causing the given symptoms. So the answer becomes Mycobacterium leprae. The next question is, a 27-year-old female comes to OPD with sudden diminishing vision in right eye. RAPD was diagnosed in the right eye while the left eye is normal. Which of the following investigations would you do subsequently? Now, before answering the question that which investigation do we need, we have to first make the diagnosis of the disease. We know that the history given to us is sudden loss of vision or diminishing vision in one eye. Okay, because there is problem in only right eye, left eye is normal. It means the condition is unilateral. The condition has RAPD. Whenever we hear of RAPD, there is only one disease that strikes in our mind instantly. Whenever we heard RAPD is optic neuritis. But optic neuritis is not the only disease showing RAPD. So we have to look at the other options also. Other options or the history says that the disease is unilateral, and this unilaterality is enough to support our diagnosis of optic neuritis. We know that optic neuritis, unilaterality, and RAPD, these two terms are enough to diagnose our condition, that is optic neuritis. And also the third thing, that is sudden. It is sudden in onset. So we come to our diagnosis of optic neuritis, which is unilateral, and RAPD is the rule in optic nerve diseases. Left eye is normal, and which of the following investigations we do? For knowing the investigation, we must know what are the causes of optic neuritis, and we always read that optic neuritis most common cause is demyelination. Demyelinating diseases, they are the most common causes, and among the demyelinating diseases, multiple sclerosis. Multiple sclerosis is the disease which is most commonly seen with optic neuritis. We know that up to 50%, half of the patient, 50% of the patients with MS will have or can have the optic neuritis. At one or the other point, 50% of the patients of multiple sclerosis can have optic neuritis, and even, two-thirds, 40 to 50% of the patient with optic neuritis, they will, at one time, they will suffer from multiple sclerosis. So this is such a common association between multiple sclerosis and optic neuritis. We know that optic neuritis is a demyelinating disease. So for the demyelinating disease of the brain, we need MRI as our investigation, and MRI is the investigation of choice even in the multiple sclerosis. There are main two investigations which we need in MS. We know that one is the invasive procedure, lumbar puncture, and other non-invasive is the MRI. Okay. Here we are not given the option of lumbar puncture, we are given the option of MRI, which gives us answer of MRI, but we have to look at the other options also. Other options are blood sugar, thyroid profile, anti-MOG and NMO antibodies. These antibodies, which are increased in a disease called Davick's disease. And we always study that Davick's disease is associated with optic neuritis, in which the patient has transverse myelitis with optic neuritis, Davick's disease. So here we have two options which are correct. If it is, multiple answer, we have MRI and anti-MOG and NMO bodies. Since now only one correct option questions are asked in INI, these two options will not be given simultaneously, but even if they are given simultaneously and we have to choose one, we'll choose the MRI. We'll choose the MRI only and not anti-MOG, because if we have to choose the B option, in the history they would have been given a history of transverse myelitis to the patient. In this, there is no other history, systemic history is given in the exam, and we have to go by one answer. We will go by MRI and not the B option. If it is a multiple answer which is not now being asked, then option A and B could be correct, or the other pattern of the question asked in INIR, you are given 4 options and the questions asked are which of the following options are correct, 1, 2, 1, 3, 1, 4, like we discussed in the previous questions also. So that could be a case scenario in that A and B, 1 and 2 will be the correct option, but in single answer, we have to tick mark MRI because no history, systemic history is being given in the question. What we also know by MRI, what we get in MRI, we give in MRI, we and the lumbar puncture, that are the investigations. In the MRI, we get periventricular plaques in the MRI as the investigation. And also, you can be asked about the treatment of the optic neuritis, which you always commonly study, that is the intravenous steroids. Oral steroids are not the drug of choice, but the intravenous steroids are the drug of choice. 1 gram methylprednisolone. Which sort of the prednisolone? Methylprednisolone is given. 1 gram once a day for 3 days, and then we start the patient on oral steroids, Okay, so this is known by the name of pulse therapy of the steroids. Other, you can be asked about the location. There are papillitis, retrobulbar neuritis, neuroretinitis. Most common is retrobulbar neuritis. In children, papillitis is most common. Okay, children, most common is papillitis. In adults, most common is retrobulbar neuritis, meaning the fundus examination will be normal. In neuroretinitis, we will have the macular star formation, or in the history, we have the history of cat scratch disease. Okay, so these are some of the findings. You can be given in the history that patient has pain on ocular movements, especially on adapting positions, pain in ocular movements. Okay, so these are some of the histories you can be given in the exam. So the very important topic, optic neuritis. So the answer will be MRI, brain and organ. The next question is proptosis in a child. Okay, the first thing is proptosis, child. Third thing, hint given in the question that the tumor is desmin positive. We have to come to the diagnosis with 3 things. Sign is proptosis, age, child age group, and on histology, the tumor is desmin positive. Now with desmin, we study in pathology also. Desmin is an indicator of growth or the striations of the muscles. Whenever there is muscular pathology seen in the connective tissue, it comes out to be a desmin positive. Okay, so this is a desmin positive tumor with proptosis in child. Even if we do not know the pathology part, we know this flow chart. Whenever we talk about primary intraorbital or intraocular tumors, in intraorbital, most common tumor in children is rhabdomyosarcoma, while in adults, it is cavernous hemangioma. And when we talk about intraocular, in adults, most common is multiple myeloma, and in children, it is retinoblastoma. You have to learn these 4 tumors by heart. Intraorbital, adults, cavernous hemangioma, rhabdomyosarcoma in children. Intraocularly, adults, multiple myeloma, and children, retinoblastoma. But these are the primary tumors. While both in intraorbital, especially and intraocular, secondary tumors are most common per se. Secondary tumors are more common. But when we talk about the primary tumors, these are the tumors which are most common. Okay, apart from secondary, when we talk about the primary, you have to learn these 4 tumors. So, in the question, we were given proptosis. It means intraorbital tumor. Child age group, rhabdomyosarcoma. Again, desmin we discussed already. Whenever there is metaplasia of connective tissue with the muscular tissue or the striated muscles, whenever there is metaplasia of striated muscles in connective tissue, the tumor shows desmin positive nature. And as the name of rhabdomyosarcoma also suggests, there is formation of muscular tissue, or there is metaplasia of the muscular tissue in the connective tissue. This is known by the name of rhabdomyosarcoma. So there were options of, even if we know this flow chart, none of the options are of the tumors which are most commonly seen. So the straight away answer becomes embryonal rhabdomyosarcoma. If the option contained retinoblastoma, it is an intraocular tumor. It will not present with proptosis. It will present, we have the symptoms like leukoporia, squint, because it is an intraocular tumor. So these will be the symptoms which will be occurring in signs of the retinoblastoma. Other things which can be asked in rhabdomyosarcoma, you can be given an image-based question about the diagnosis. Most common location of rhabdomyosarcoma, there will be a mass in the superotemporal part of the orbit. In the superotemporally, it will be growing towards inside. It will be growing towards the center, starting from the superotemporal area. Towards the superotemporal area. Similarly, on the similar lines, and question was asked in NEET-PG about there was a confusion about the lipodermoid and the limbal dermoid. So this was the similar. I don't know if was it an image based. Some were saying it is image based. Some were saying it was not image based. But the most common location superior-temporally is of the rhabdomyosarcoma. Other is the dermolipoma. Other differential diagnosis is dermolipoma asked in NEET-PG. And if it is on the limbal area, it will be the limbal dermoid. Okay. And the most common location of rhabdomyosarcoma will be superior-temporally. This can be asked as an image-based question. The next question is most common lacrimal gland tumor. Again, the tumor, we have some few one-liners again to remember by heart. Most common lacrimal tumor. There are 4 options: pleomorphic adenoma, mucoepidermoid, adenocystic, and non-Hodgkin. We have 2 tumors which are most commonly seen in lacrimal gland. One is pleomorphic adenoma and other is adenocystic. Pleomorphic adenoma is the most common benign lacrimal gland tumor. Adenocystic is most common malignant tumor. Now we always know that benign are very, very common than a malignant tumor. So we have to, by default, tick the answer as the benign condition, that is the pleomorphic adenoma. Because benign conditions are more common than malignant, so the answer will become the benign condition, that is the pleomorphic adenoma. So we get here 2 one-liners: most common benign lacrimal tumor, pleomorphic adenoma. Most common malignant lacrimal gland tumor, adenocystic carcinoma. Other one-liners: most common lid tumor, benign papilloma. Most common lid tumor malignant is basal cell carcinoma, or with the name of rodent ulcer. You can be given in the history rodent type ulcer, okay? That is basal cell carcinoma. But if it is specifically asked, most common upper eyelid tumor is sebaceous cell CA. Then it is sebaceous cell CA, not basal cell CA. If asked specifically about the upper eyelid. Upper eyelid is sebaceous cell carcinoma. Most common malignant tumor in recurrent chalazion. We always discuss in the history also. Even if you are given a question of chalazion, that a patient is suffering from recurrent chalazion, what will you suspect in a patient? What can we suspect in a patient? If it is a child, we can suspect refractive error. We can suspect refractive error because of the constant rubbing of the eyelid. Patient is developing recurrent chalazion. Because the patient has refractive error, child has refractive error, he is not able to understand that he has blurry vision, or is not able to convey that he has blurry vision, but he is continuously rubbing his eyes to look clearly, and the patient suffers from recurrent chalazion. In a child, most common cause of recurrent chalazion, refractive error. Most common cause of recurrent chalazion in an adult, we have to differentiate between 2 things. Either the patient has diabetes mellitus, or the patient has malignancy. Diabetes mellitus could be a common cause, or in the rare cases, patient can have malignancy. And if a patient comes out to be a malignant case, which of the tumor patient will be having? The patient will be having sebaceous cell carcinoma. So the sebaceous cell carcinoma will be in recurrent chalazion and upper eyelid tumor. As a whole eyelid tumor, basal cell carcinoma, but benign tumor will be a papilloma. So these 2 questions that are the one-liner questions about the tumors. Most common, we always discuss about the melanocytic tumors in the conjunctivis, conjunctival nevus. That is not the malignant melanoma. Another one line can be asked: conjunctival tumor, melanocytic conjunctival tumor. Most common is conjunctival nevus. It is conjunctival nevus. Okay, so these are some of the one-liners. A patient with aqueous flare and KPs presents with raised intraocular pressure. Which of the anti-glaucoma drugs should be avoided? We always discuss pharmacotherapy of glaucoma, a very important topic. We always discuss the mnemonics for the pharmacotherapy of glaucoma, as we know that two main: decrease production, increase flow, discussed already a few days ago. A, B, C, alpha agonist, beta blockers, carbonic anhydrase inhibitors, increasing flow either through trabecular meshwork or UV flow through the prostaglandins, PGF2 alpha, trabecular meshwork, by natars to DIL. These are the drugs which increase by, decrease the IOP by increasing the trabecular meshwork outflow. Okay. So these are some of the drugs which we always discussed, and we already discussed in our previous session also. Now we are being asked about the side effects of these drugs. So let us have a discussion, a quick revision of the side effects of the anti-glaucoma drugs, because these are also discussed, asked very commonly. Firstly, we'll start with this ABC. Alpha agonist. Mainly we discussed about the two drugs, apraclonidine and brimonidine. In apraclonidine, you have to remember two things: conjunctivitis. Which type of conjunctivitis? Follicular conjunctivitis and lid retraction. For apraclonidine, follicular conjunctivitis and lid retraction. In brimonidine, we always study it causes CNS depression, very characteristic of brimonidine, and that is why on the similar lines we are always asked about this question, that which of the anti-glaucoma is contraindicated in children or below the age of 2 years is brimonidine, because it causes CNS depression. It can cause apnea to the child. It can cause apnea because it causes CNS depression. Next drug we discussed is beta blockers. Alpha agonists cause follicular conjunctivitis. Beta blockers cause blepharoconjunctivitis. They cause blepharoconjunctivitis. Apart from this, they also cause dry eye syndrome or the keratoconjunctivitis. Dry eyes. They also cause superficial punctate keratitis. They also cause superficial punctate keratitis, that is SPKs. So we can know or learn this by BDS as the mnemonic: blepharoconjunctivitis, dry eye, superficial punctate keratitis. The third drug, ABC, carbonic anhydrase inhibitors. Main drug we give is acetazolamide. First thing, we are always asked about the carbonic anhydrase inhibitors. These are the class of the drugs which can be given both orally and topically. Orally in the form of acetazolamide, topically dorzolamide, brinzolamide. They can be given both orally and topically. Carbonic anhydrase inhibitors, again a previous year question. They are contraindicated in sulfa allergies. And they are also associated with metabolic acidosis. Okay. The fourth class of the drug, prostaglandins analogs. We always know prostaglandins are pro-inflammatories. They are included in the inflammatory cascade of arachidonic acid, prostaglandins. So they are pro-inflammatories. That is why they can cause cystoid macular edema. Other things they can cause is hypertrichosis. They can cause excessive growth of the eyelashes, that is hypertrichosis. They can also cause iris pigmentation. They can cause iris pigmentation. That is why they are contraindicated, because they cause cystoid macular edema. They are contraindicated in any eye which has a history of prior inflammation like uveitis. Okay, because they can cause cystoid macular edema. All of these three things have been asked previously, either in NEET or INI. Other class of the drugs, neotics, that is pilocarpine. Pilocarpine is one such drug which affects almost all of the parts of the eye, from the anterior segment till the posterior segment. Okay, it can affect most of the parts of the eye. It can cause myopia, which has been asked as a previous year question. It can cause retinal detachment because it pushes the lens iris diaphragm forward, so it leads to myopia. It can lead to retinal detachment also. It can cause conjunctivitis also. So the pilocarpine, they they have been associated with the, it can have multiple side effects in almost all of the parts of the eye, which it can cause from the starting, even in the orbit. It can lead to brow aches and headaches. It can lead to brow aches and headaches. It can cause iris twist. It can cause myopia. It can cause retinal detachment. So these are some of the side effects of the myotics. Next, we talk about the rho kinase inhibitors, that is the nitarsudil. They are most commonly associated with conjunctival hyperemia. They are associated with conjunctival hyperemia. They can cause conjunctival hyperemia. These are main, it can cause conjunctival hyperemia. It can cause blurry vision also because of the conjunctival hyperemia, which is the main side effect of the nitarsudil. Also, one of the side effect of the nitarsudil seen in less population, which is we known by the name of vortex keratopathy. Some of the patients on nitarsudil, they have been found to be suffering from vortex keratopathy or cornea verticillata. That is, we always read as a side effect of hydroxychloroquine and chloroquine, but it can be seen, it has been seen in a few patients with rho kinase inhibitors, but mainly you have to remember that it is a part of hydrochloroquine, but it can be seen as a part of nitarsudil. So these are some of the side effects of the anti-glaucoma drugs which you must remember. Next is, safe strategy includes all of the except. Firstly, we know that safe strategy is included in the treatment of trachoma. And as per WHO guidelines, safe means surgery for trichosis, because we know that there is misdirection of eyelashes seen in the trachoma, so surgery for that. Antibiotics, we know that which type of antibiotic, azithromycin is the drug of choice. Antibiotics for the infection, facial cleanliness, and environmental approach, environmental improvement. We know that fly as a vector of trachoma. So environmental cleanliness, facial cleanliness, they all are part of the program of the elimination of the trachoma. Safe strategy, surgery for trichiasis, antibiotics, facial cleanliness, not the evaluation of program, but the environmental cleanliness or the environmental improvement. Some of the image-based signs seen in trachoma, these are the follicles seen on the conjunctival sago-grain follicles seen in the trachoma. This is the pannus, where there is new vascularization in the cornea, pannus. This image, conjunctival scarring is seen, which is clearly seen in this image. That is the conjunctival scarring, known by the name of Arl's line. This is the small excavation seen in the limbal area with the name of Herbert's pits. And this is the marked trichosis. There is a misdirection of the eyelashes seen in the trachoma. So these are can be asked as the image based question as a part of trachoma. Next is the following feature is not seen as an optic disc change in glaucoma. Not seen. The options are Reni's nasal step, bayoneting sign, increase in cup disc ratio, bearing of the nasal artery. If we have studied glaucoma by heart, we need not to go into the details of the question. We know that the answer is Reni's nasal step, because all of these are the optic disc changes. But if we are not sure about the question, we can get confused because all of these are the features of glaucoma. But the question is not the feature of glaucoma. The question is feature of glaucoma as a part of optic disc change. And we know that Reni's nasal step is a change seen on visual fields, not on optic disc or the fundus examination, but as a part of visual field change. So let us quickly revise the optic disc changes. Firstly, we know that the first and the very characteristic of glaucoma is the optic cup disc ratio increase. There is oval cupping of the optic disc, that is increase in the CD ratio from normal 0.3. Whenever it is more than 0.7, it is straight away glaucoma. The lesser, they are glaucoma suspect, or we need other features also to diagnose them. So there is vertical elongation of the cup. Since the cup is increasing in size, this healthy neural tissue will decrease, known by the name of neuroretinal rim. So increase in CD ratio with thinning of the neuroretinal rim, that is the normal healthy retina. And this cup is nothing but just a empty space. The white color is due to the shining of the sclera. So this is cup is without any healthy tissue, and neuroretinal rim contains the healthy tissue. The first thing is this. Other disc changes, hemorrhage, where around the optic disc. Around the optic disc, hemorrhage is seen. Peripapillary. We know that optic disc is known by the name of papilla. So around papilla, peripapillary hemorrhages, that is splinter hemorrhages. Not pathognomic, but seen in glaucoma. This is peripapillary hemorrhage. What is this is? This is the bearing of the vessels. What is happening is, because there is increase in the cup, that is, there is decrease in the neural healthy tissue, the vessels, especially the horizontal vessels, they appear to be hanging. They appear to be hanging whenever we do the examination, because behind them there was a healthy neural tissue. When this healthy neural tissue has decreased, these vessels they are seen to lying bearing. There is bearing of the vessels. They are seen to lying without the support of the tissue. So this is known by the name of bearing of the vessels. These vessels are shown, or supposedly they are seen like they are hanging without any support. So they are hanging without the support of the healthy tissue, especially seen in the horizontal vessels, known by the name of bearing of the circumlinear vessels, bearing of the horizontal circumlinear vessels. Next, this is the bayoneting sign. What is happening in glaucoma is there is increase in the cup. There is increase in cup. It is becoming deep. The cup is becoming deep. The optic cup is becoming deep. So the vessels, they have to travel a longer distance whenever they are coming out of the disc. So they are taking a sharp bend. Whenever they are coming from a deeper area, they will take a sharp bend whenever they will come out of the optic disc. So the sharp bending or the double angulation, one, they will take a bend at the part where they are approaching, entering the lamina cribrosa. Another part, they will take a sharp bend at the margin of the optic disc. So there will be double angulation. There will be double angulation of the vessels. This is known by the name of bayoneting. This is known by the name of bayoneting sign. Double angulation or increased, bending of the vessel. Other is this is collateral vessels. Increase in collateral vessels. Increase in the collateral vessels. Other is there are small blackish dots seen with the name of laminar dot sign. Another also sign shown here is these vessels which were earlier coming from they were seen to appear from the center of the optic nerve have shifted toward one side, towards the nasal side. This is known by the name of nasalization of vessels. Nasalization of vessels. So these are some of the optic disc changes seen in the glaucoma. This is again a diagram of the bayoneting sign. Wherever there is a sharp, steep angulation of the vessels at the optic disc margin. So the answer becomes Rini's nasal step, which is a part of the visual field defect. What are the visual fields defects? The first sign is the paracentral scotoma. Away from the center, paracentral scotoma. Next is this paracentral scotoma. This is the normal blind spot. It joins this blind spot. Paracentral scotoma joins this blind spot. This is known by the name of sedal scotoma. This sedal scotoma then travels towards other side also and takes the form of arcuate, known by the name of arcuate scotoma. This arcuate scotoma then appears on the other side also. This is the double arcuate scotoma. Now this Rini step appears in this double arcuate step. These both arcuate scotomas, they are not exactly similar. There is a space between these two scotomas. There is a space seen between these two scotomas, and this space is known by the name of a nasal step. That is the Rini's nasal step. They are not exactly equal. There is some space left, known by the name of nasal step. Then they spread towards the whole periphery, and then there is contraction of this vision, and ultimately the patient left with tubular vision. And another question asked in NEET, which vision the patient has, which is the vision last to go in glaucoma, is the temporal island. Temporal. Don't get confused with this first image. This is not showing the arcuate scotoma. This first image is basically they are showing what is the Jerum's area. This is Jerum's area. The 0 to 30 degrees part from the blind spot is normally the Jerum's area, which is shown in this diagram. The glaucomatous changes, they start from the paracentral scotoma. This is a normal finding or the normal area which they have shown in the diagram. So that is why this arcuate scotoma is also known by the name of Jerum's scotoma, because it involves the Jerum's area. So these are the first is the Jerum's area, next paracentral, sedal, and other arcuate, double arcuate, nasal step, tubular field, and only the temporal island of field of vision. Okay. So these were the questions, previous year questions. We have discussed the previous year questions in 2 sessions, and I have tried to complete all of the previous year questions of INI from the last 5 years. But still, I would like to enumerate the important topics, since first important topics we always say is the previous year questions as far as the Central Institute exam is concerned. So, but they are not always enough. You have to look at the other topics also. The first high yield topic will be the previous year questions, no doubt. Okay, you have to revise. There will, these PDFs will be there with you. Earlier PDF also, this PDF will be also, you can revise them. But other topics which we need to remember or learn or revise, because we have already learned them, we just need to revise them. As far as anatomy of the eye is concerned, we need to know the extraocular muscles supply as well as their actions. Embryology is also asked, but not so frequently. But we always, we have learned the mnemonics of the embryology. You need not to go into very detail. We have learned the mnemonics of the embryology. We just remember that only, and your embryology part is covered. For the extraocular muscles, supply actions, and on the actions basis, Bach 3-step test, because that is always asked. Actions of the muscles is asked, and you can ask about the paralytic spin as far as the anatomy of the this is concerned. Next important topic is the systemic drugs which have ocular side effects. Systemic drugs which have ocular side effects. They are very commonly asked. Hydrochloroquine, hydroxychloroquine. It is very commonly asked. Even the systemic diseases which have ocular manifestations. Systemic drugs as well as a systemic disease with ocular manifestation, like Wilson's disease, KF ring, a very, very common ask. Diabetes mellitus, hypertension, tuberculosis, sarcoidosis, very important topics. Okay, so systemic diseases as well as the systemic drugs. Steps of cataract surgery, very, very important. Steps of the cataract surgery. In the surgery part, cataract surgery steps and its instruments. Okay. Also, some of the clinical aspects. Clinical aspects meaning the procedures. The procedures like how do we measure gold, how do we use Goldman applanation tonometer? Okay, how do we use or how do we perform the surgery of the chalazion? It can be asked. How do we do OCT? What are the clinical aspects of the FFA? So these are clinical, because clinical questions are being asked. So these are some of the important topics. Clinical aspects. Snellen's chart is very, very important. Lennon's chart, very, very important. Okay, so these are some of the high yields topics. You cannot forget endophthalmitis. You cannot forget endophthalmitis. So these are the topics which must be in your mind whenever you are revising. And we know that with less than a month left for the exam, we need not to start any new topic. We just have to keep on revising everything. We have already prepared for the NEET-PG exam. We know everything. We just have to revise and revise. No new thing, no new topic to be started now. You just have to do the previous year questions. You have their PDFs. Just revise from them. You have your notes. Just keep on revising them. Okay, you can give your grand test. Always give your grand test. Okay, and just revise from the PDFs and the notes you have. Do not start any new topic. Okay, and we are always available to you whenever you need. With only few days left for the exams, we are always by your side. Whenever you need, you can text anytime and we are there to help you. And all of the best for your exam. Keep on studying hard. You all will do very good, and all the best for exams. And do not lose your calm, and just keep on revising and revising. So this is for this session, and all of the best for your exam, and hope to see all of you with very good results. Okay, thank you, and